right. So now we start our part 2. CGRP antibodies, do they work and do they have side effects and are they dangerous, right? So this is a bit of an overview of the research on CGRP antibodies. I will not make comparisons between Aimovig, Ajovy, and Emgality. I'm just going to give you ballpark figures from science. Okay. What do we have in Canada available at present time to treat migraine, to prevent migraine? Aimovig, Emgality, Ajovy. Vyupti, that's the American name, is likely to come in Canada in 2021 or 2022. It's going to be intravenous, an infusion, right? The others come as injectors or syringes. Usually there's one dose, but there might be a loading dose, and there might be ways to inject every 3 months or only every month. And you can just look at the cost, the last line. Those are not cheap things because these are new antibodies, bioengineered. Just for the record, this goes up to 500. So that would be something like $10,000 to $12,000 per year. Many biological agents, antibodies for multiple sclerosis, Crohn's disease, arthritis, are up to $50,000 per year. So these ones are expensive, but they're not that expensive for that type of treatment. Okay, so how do they look like? They look like those are the boxes, right? So you have the boxes with the injectors. Emgality and the Aimovig, come as self-injectors, a bit like EpiPen, right? And if you start these, you will learn how to self-inject. Ajovy comes as a little syringe. There's pros and cons. The injector, you just inject. The syringe, you control it. Some people like to control, to inject slowly. Others say, there's no way I can manipulate the syringe. I'm going to have the injector. Others say the injector just is too fast. It hurts. I prefer the syringe. It's a matter of preference. Okay, so will they work? Do they work for people who try them? Maybe you have tried them already, but let's have a look. How do we look at prevention success in migraine? We look at decrease in headache days and decrease in acute medication intake. So if you're taking every month 12 triptan doses, right? And then if you take something and you go down to 6 triptan doses, that's a 50% decrease and it's a success. Depending on where you start, different responses might be significant. So let's say you have 10 migraine days per month and you have 50% better. You have 4, you go down to 4, you lose 4 days, that's great. But let's say you have chronic and then you have 22 days to start with, and then you have a 30% improvement. So that's still 7 days of improvement. That's actually significant. It's a whole week back. So that's a problem with insurance companies because insurance companies, based on research, they ask for 50% response, right? So that's one of the issues we'll discuss later. Some people have super response. They are 75% better. So if you start at 21 days, it means you're down to 7 days. You say 14 days, that's great. You may also see that, okay, you have less attacks, maybe not that many less, but they're less severe. You don't throw up anymore. You don't have to go to the emergency, and you can control them with your usual therapies. So this is how we evaluate response to prevention. And that's also, all of this eventually leads to a better life for you, where you can, plan your party and attend the event and work and maybe, train or a glass of wine and enjoy life, right? All right. So that's an example with a migraine tracker. So the tracker I just showed like a 1 monthly diary to show how it looks like when you send to your doctor. Here, this person started with 18 days and went back down to 11 days. So that's a 40% response, but also had less severe days. Had more severe, but had less mild and moderate. So that's just an example on how a diary will help you to monitor your success. Okay, graphs. Graphs are not always easy to get, but let me walk through this. You will see here in the graphs in blue, that's the placebo, people who took a sugar pill or a neutral injection during a study. In red, you have the active product, in this case, the oral medications, Elavil, Andral, propranolol. And on the right side, you see the 3 antibodies. So I put little acronyms there, but ENM is Aimovig, the middle one is Emgality, and the last one on the right side is Ajovy. Right, so this and the bar that you see, the little fine blue line, is 50% response. So everything that's above that is more than 50% response, and below that is 40% of people or 50% of people. So let's look at our oral medications that we had. So usually this 50-50 ballpark I talked about, not everyone was reaching that, right? So Elavil and propranolol did not reach really a 50% response in trials. Topamax or topiramate did, but overall the ballpark is 50. If we look at the antibodies, they do better. They're closer to 50 or above 50 even for Emgality. So they do reach this 50% bar of 50% improvement for episodic migraine. So episodic would be a mean of 8 to 10 days per month of migraine, but less than 15. Okay, but now if you're here, it might be you have chronic migraine, which is the most severe form, where you might have more than 15, 20 days, or even every day a headache with some migraines patched over that. And this is not a fun way to live. And that's actually 1 to 2% of Canada's population and the world's population. So you're not alone in this. Okay, so this is the same graph, same concept. Blue is placebo, orange is the actual treatment, and green is the gain, the difference between both. And you can see here that this is the decrease in monthly days. So how many days do you gain? And now we compare Topamax and Botox to the antibodies, the 3 of them. You can see that Topamax and antibodies gain approximately 6 days better on a mean. Botox fares a bit better with more than 8 days. That's 8 days less of migraine or headache. So that's great. Remember that this is all the people. So if you remove the people who did not improve, or if you look at people who did improve a lot, it means that you can gain back, like I said before, 10 to 14 to 20 days. Okay, so if you're a super responder. So what about people with chronic migraine? And bear with me, I have just 2 or 3 more slides with graphs, and then we're back to no graphs. So here are the results of chronic migraine. So chronic migraine, if you want a 50% response for Topamax or Botox, that's 30 to 46% of people will reach that. 3 to 4 over 10, okay? Antibodies, it's 3 to 4 over 10. So it's very similar, right? So there's actually, we cannot say that the antibodies are the silver bullet, they treat everyone. Their 50% response rate are similar to topiramate and Botox. Some people are super responders to, and now you have the super response for all antibodies for episodic or chronic, right? So the message here is whatever you've tried, okay, and whatever you've done before to treat your migraine, if you have the software, the sensitivity, if you're determined to respond to a CGRP antibody, it looks like you will. And there's probably 3 people over 10 and 2 people over 10 trying these drugs who will fall into this super response category where the benefit will be very clear. So that's what we hope as clinicians. That's what you hope as a patient, the super response. So 3 over 10 if you have episodic, 2 over 10 if you are chronic. All right, let's take a little breath. There's a lot of graphs, but I just wanted to show you what I showed to actually your GPs. This is what I show them, right? I'm showing you the exact same stuff, right? Just to tell you what we saw in the clinical trials about those medications. Another key question is how long should you try them? Because usually you take these injectors and you inject yourself every month, but how many months? In the clinical trials, usually The response was seen sometimes as early as the first month, especially for the super responders. It's like, boom, you hit the right thing, you get way better, and then you're very happy, and then usually it stays like that. But some people have more severe chronic migraine. They may start from a very, very deep and tough place. And what we've seen as experts, and we talk among ourselves, what we've seen is that sometimes it doesn't work after 1 or 2 or 3 months. Sometimes you need 4 or 5 or up to 6 months. I would say after 6 months, if there's no response whatsoever, it would be very surprising to see a benefit from those antibodies, right? So the message here is you might get better the first month right away, but you might need more time than the 3 months that are, you know, the ballpark that they use in the trials. Is it going to last, right? Are you still going to be better a year later? In theory, yes, right? So this is actually data from all the studies on Aimovig, HOV, and Emgality, showing that 3/4 of people that were chronic, 15 plus, just went down to episodic. And at 1 year, they were still there. So it means that somehow, if you're chronic, you have 3/4 of a chance to actually get back to episodic. Doesn't mean having no migraine, but being improved. Okay. So now let's talk about side effects, because as a physician, I do prescribe tons of pills. And I know some of my patients will get back to me and say, my God, I tried this. I was a zombie. I gained weight. I had a tremor. I lost my hair. I couldn't think straight. I had no libido. My blood pressure went down. I could not train anymore. This is not good, right? That's not what I want for my patient. I want my patient to get better without gaining weight or fainting or being a zombie. So side effects were a key problem with the drugs, the oral medications. And if you've tried them, you might know some of these side effects. So good news, right? So actually, I've showed you before that the antibodies have similar benefits, a little bit better, right? Or close, or a little bit less than Botox actually, but pretty close. They don't treat everyone. Not everyone responds. But where they gain is that they are better tolerated. So in clinical trials, that means thousands of patients total, less than 2% of people decided to stop the drug for side effects. So that's actually pretty good, because for oral medications, it's 5 to 10%. So that means that people said, you know what, maybe I have a side effect, but I'm going to bear with it. It's not that bad. It doesn't mean there were no side effects. There were side effects. I'm going to show you. But they were not severe enough for people to leave the trial. So that's actually encouraging. Okay, what are the side effects? Injection site reactions. So those drugs may cause redness, swelling of the skin. It can happen. It can get sometimes pretty bad. You know, it's swollen and big and red. Discuss that with your doctor, right? If it happens, sometimes it can be managed. Sometimes you have to stop. So that's something we can see. And that's probably more than 2% of patients, probably around 5 to 10%. Constipation is common. In the studies, we didn't see it that much. But, you know, a lot of people are taking Elavil, which is very constipating. Some of them are taking codeine or opioids, very constipating. Some people have constipation to start with. So usually constipation is probably 1 person over 5 for Aimovig, maybe a bit less with the 2 others. Usually it's mild to moderate, and it can be managed with diet or laxatives or stuff, but it is a problem. So if you are known to have severe constipation, this should be discussed with your doctor. Allergy may happen, okay, with all of these products. We call that hypersensitivity reaction, you know, hives or a swelling of the throat, that kind of thing. It may happen. It is rare, but it can happen. Fatigue and muscle pains are flu-like symptoms, right? Feeling tired, having pain, joint pains, that has been reported. And then some people have reported a transient increase in headache. So that's what we see the most commonly. Now, if you go to social media and support groups, you will see a bunch of other side effects, right? Nightmares, panic attacks, sleep issues, weight gain, weight loss, hair loss. And it's a bit surprising to us because when we discuss with the big American clinics where they have thousands of people, they don't see that often. So why is that? Well, first, it's possible that in real life, people are different than the people who go to these studies. And maybe people have more problems, more medications, and they have more side effects. So this is not new. It's not new, actually. Usually side effects in real life are always a bit more than in the studies. So it might be that they've been underestimated. On the other side, it's also possible to have what we call the nocebo effect. Some people take a sugar pill and they have a benefit. We call that placebo. It's great. Some people take a sugar pill and they have side effects. That's kind of a dark side of placebo. And it happens. And we know because in studies, we give tons of sugar pills to people and they still have side effects. And those are mediated by expectations. So they think they're going to get bad and they do get bad. It's exactly like placebo, but reverse. And the other problem is that people who do go to support groups, and those support groups are great, people do support each other, it's very important, but those are usually not happy campers. They are not people who are super responders, because then if you're doing so much better, usually you stop going to the support group. So it might be that in support groups, there's a bit of an overrepresentation of people who have side effects. Just be careful with that if you go, and remember that these medications are usually way better tolerated than the oral medications. Whatever happens, if you have a reaction to a product, any product, always talk about it with your healthcare provider. Okay, are there people who cannot take the CGRP antibodies? I didn't mention it there because I don't do peds, but anyone below 18. So any kid or teen, that's like that. There are trials in children and teenagers, but they're not there yet. So Health Canada does not allow CGRP antibodies for young people, apart in the study. CGRP does play a role in pregnancy. If you are planning a pregnancy, or if you are pregnant, you should not be taking these meds. And because the antibodies stay in your system for quite a bit, you should probably stop taking antibodies 4 to 5 months before even starting conceiving. Okay, so this is really something you have to think about if you're a woman and if you're talking or thinking about having a child. Breastfeeding, it's a matter of caution. So usually we do not recommend to take those drugs during breastfeeding. Discuss with your doctor. CGRP plays a role in our vascular bodies and our vascular system, blood pressure, the heart, the kidney, the brain. So at present time, there's no formal contraindication in kind of the label of Health Canada, but many of us experts, we will be cautious if we have patients who have a lot of vascular issues, uncontrolled diabetes, hypertension, recent heart problems, that kind of thing. It's caution. Discuss this with your physician because there's no official rule, but you may hear about it if you suffer from a lot of vascular troubles. Severe constipation, I talked about it. And in the studies, usually the studies have not included above 65, apart from some studies with Emgality. So this also, you may be declined by insurance companies for that reason. So discuss with your physician. And I have to underline that because I'm actually telling you a lot of medical stuff here. And my goal is to help you, but I also have to just be careful not to give you, the Holy Bible thing, and maybe it wasn't clear, and maybe I didn't think about your particular case. Discuss with your doctor whatever medical treatment you're doing. Okay, so the big question before we discuss coverage is there one best antibody? The answer is no. They haven't been compared to one another. All the studies actually showed very similar results. So it's the same thing as the whole headache medicine mojo or rule, which is one size does not fit all. So you may have to try one and then another, who knows? So let me show you, because maybe you've tried one and you want to try another. Let me show you data that's done by a guy I know, Dr. Larry Robbins, in the States, in Chicago. And he has a big clinic. So he recorded the patients that he switched and who started with, let's say, Aimovig was the first to market, switched to Emgality or Ajovy. And then he actually looked at if people were switching because they did not respond, because they had side effects, or because the insurance was not covering anymore and they wanted to switch to have some financial support from a new antibody. So as you can see, if you switch for financial reason, which is the fourth column, financial, well, you have a good chance of responding, 50 to 60% chance of response. And those were very tough patients, so it's a 30% response, not the 50. So if you switch because your company, your insurance is not covering, and you responded to the antibody, of course, you have a good chance of responding to another. If you switch because the first one didn't work, then you have a lower chance, but you still have a chance, probably around 20, if we just look roughly, maybe around 25, 30% chance. So you still worth trying, right? And if you switch because you have side effects, it's a bit similar. And that seems to be the case for switching between Ajovy, Emgality, Aimovig. So we need more data, but I think this is important for those of you thinking about switching an antibody to another. Part 3, welcome to part 3, CGRP antibodies, coverage and access. So we have said, and we have discussed together, that first, CGRP antibodies are a groundbreaking new scientific thing in migraine world, because for the first time, we target something we know that plays a role in migraine. That's new. So scientifically, it's great. We know that all the studies on CGRP antibodies have shown effectiveness. Not for everyone. So maybe 50% of people with episodic migraine, 40% of people with chronic migraine will improve by half or more. And there's maybe 25, 30% chance of being a super responder, which is great. Still, 40 to 50 to 60% of people will not respond to those drugs. And it's okay. I mean, science is still evolving. There might be other targets, other things. They are well tolerated for a majority of people, and they are safe to use over years, up to 5 years. We have data for Aimovig. So that's what we have. That's what we are. So now, will my insurance cover them? All right. So this is where we enter the world of coverage in Canada. And you have to remember, and I didn't know, we don't learn that stuff in medical school, because medical school is about medicine. It's not about insurance companies. But soon enough, when you're a doctor, you discover that you have to deal with insurance companies if you want to help people. So in Canada, there's between 50 and 60% of people who are insured by private payers. Sun Life, SSQ, Manulife, Blue Cross, Green Shield, name it. One thing I learned, and it's very crucial, is that you cannot just say Sun Life covers Emgality or SSQ covers Ajovy. They have plans, and the plans can be the super, top VIP plan, or it can be the little plan for, a smaller employer, for example. You can't ever be sure that your private insurer will cover these medications. In the public side, public is complicated because it's like, first we have different public system in all different provinces. And so what usually happens is that the drug is examined by something called CADTH, which is the Canadian Agency for Drug Technologies and Health. And they look at the results, what I've just shown you, and they look at the cost. And then they say, okay, is this a good product that we want in Canada? So First Health Canada says the product works and it's safe. Then CADTH says, okay, is this something that we public covers or insurers should pay for? And then there's something called the PCPA, which is a Pharmacological Alliance of Canada or something like that. And they do negotiations about the cost, right? They don't have that in the States. And that's probably why the States is paying humongous costs for their meds, right? So that's overall a good system. And sometimes the private payers listen to what's or look at what's going on in the public world, and they kind of adapt to it. Okay. So Aimovig, which is done by Novartis, Aimovig has been evaluated by CADIF, and they have had a positive recommendation. Okay, so that's very good, because if it was declined and they said, no, public's not going to cover, then that would have been the end of it, or a very bad place. But now it's covered. I'll show you the criteria in just one sec. And overall in Canada, there's 0 to 10% of people, depending on province, that have to pay out of pocket. And if you don't have any coverage, you have to pay. That's just we've had some comments from people on groups or on our Facebook. I don't have coverage. What do I do? Well, that's really too bad, but you may actually consider trying to get coverage, because it's a difficult situation. All right, so let's look at the criteria. Okay, so if you have private coverage, and those are criteria that the private people, insurance companies, they decide based on their own analysis of the drug. So usually basic things for private is that you have to have 8 or more days of migraine per month to start with. In Canada, Health Canada just approved Emgality, Ajovy, and Aimovig for 4 days of migraine per month and plus. Okay, so medically wise, you could have it if you have 4 more. But private insurance and public actually said, well, 4 per month it's not worth the cost, so we won't cover it, but 8 plus. And you have to have tried and failed or not tolerated at least 2, and sometimes 3. Okay, so that's for private. So usually if you have private, your doc will say, great, let's start this antibody. I'm going to fill this form and prove that you have 8 days, and then you've tried 1, 2, 3, and then you're good to go. For public payers, so public payers at present time, CADIF only evaluated Aimovig, right? So Emgality was not submitted to CADIF, so we don't know what's going to happen there. And Ajovy has been presented to CADIF, but is on hold at present time. We'll see what will happen. But let's look at the criteria for Aimovig that has been recommended. First, there's no 8 plus. You need to have chronic migraine, 15 days of headache or migraine. You need to have failed or not tolerated or have a contraindication to 2 or 3 previous trials. And then here's the little weird thing. If you have failed 4 or more, and then there's for no efficacy, then you cannot have Aimovig. So it puts you in a weird place, right? Because what? If you failed not enough, you cannot have it. If you failed too much, you cannot have it. So I'll tell you the little trick here, and you may share that with your doctor. The 2 or 3 previous trials can be for efficacy or side effects or contraindications, but the failures are only for failures, no efficacy. So it means in theory, you can have tried 5 drugs, but 2 you had side effects, and you're good to go. All right. So this is a little twist, but I think it's useful. And then they also will ask for your number of days per month. They may ask for specific questionnaires, which we have in the app, and then they will recommend for 6 months. Okay. Patient support programs, if you have been on, so those are support programs that the companies, the pharma companies, so this is Novartis, Eli Lilly, and Teva, they support to offer a bridge or financial support. They pay for the drug virtually when you start it. So Aimovig, their support, this part's terminated in September. Lilly is still ongoing, and Teva just started, but for people with private coverage only. They're not going to bridge people with public coverage, which is really unfortunate, but that's the decision. The patient support programs will assist you in with coverage criteria and negotiations. I'll tell you how they do that. They will support you with injections and questions, and then they may provide a copay. So let's say your insurance company says, oh, we're going to pay 80%. They might provide a copay of 20%. So you don't pay anything, which is great. And that can be on the long term. So those are the patient support programs. and your doctor has to fill a form to register you to these, right? And then your doctor will have to probably deal with the insurance companies to tell them, this patient needs this drug, this patient has tried so and so, this patient is disabled, and please do provide and pay and cover. So I just have to say here, just please remember that your doctor, we are doing this, we want to help. It takes tons of our time, and we're doing this because insurance companies ask us and the pharma industry ask us. But this is really a part that takes a lot of time, and hopefully somehow we'll find ways to do this faster and better for you guys. But this is something that is a burden on us, and we really wish that it was more simple for everyone's sake, right? So what are we doing? And we're about to finish before I take questions. Migraine Canada is working for access to therapy. That's one of our goals. You know, we want to raise awareness, we want to bring some support, medical information, but we are also working on access to care. And this is a bit what we call advocacy. And it's going to be a topic of Dr. Lena in November for on our next webinar. So we did participate, and you did, guys, you did fill surveys and you participated to the CADIF and INES process. INES is the CADIF of Quebec, okay? That's a group of people who look at drugs and they decide if public coverage is gonna cover or not. We did send letter to CADIF. We did send letters to health ministries to start telling them that those are important medications for people with migraine. We are in the process of sending letters and information to major private payers to try to negotiate. What are we defending? Well, we're defending, you know, we want people to be able to try those medications, and if they're responders, that's great. So we want public coverage. We want less restrictions so more people can try. We would like to have more flexibility in the definition of response, not ask for a 50% response or more, you know, and chronic should be 30%. And we also ask for the difficult situation of combination with Botox, where most of insurance companies refuse to cover for that. But for some of you with, you know, deep chronic migraine, Botox with an antibody is the key. So we will need your voice. Stay tuned. Now I've covered everything. I hope you enjoyed it. And now I'm going to just underline that access to migraine care, it's a teamwork, and it's you, it's your physician, it's your network, it may be your employer, and Migraine Canada wants to help and wants to be there. We're growing, we're young, but please, please, please share about what we're doing if you believe in this cause, and help us to grow, because the bigger we are, the stronger we'll be. And believe me, with 4 million people with migraine in the country, we should be able to make a difference.